things that you get to do in interventional endoscopy. So why am I talking about improving experience in the endoscopy unit? And a lot of this actually is related to the ASGE, and this is one of the past presidents of ASGE, H. Worth Boyce. And he got the Schindler Award, and he was an esophagologist, did a lot of the work on dilations, way back when. But when I was a junior faculty at this point, out of fellowship, he wrote an article that always stuck with me, and I just remembered it was an editorial in GI endoscopy called "Behavior of the Endoscopy Unit." And maybe that's because I was seeing a lot of bad behavior in the endoscopy unit, so it kind of resonated with me. But it was, it resonated. And so, a couple of things that stuck with me when he did this, common sense, courtesy, compassion, and respect for the patient go a long way towards ensuring procedural success, comfort, and safety during all of our procedures. And he also says this, I tell our fellows too, because this is really important. Understand that for many patients, endoscopic invasion of the body is a major once-in-a-lifetime occurrence. Consequently, every effort should be made to ensure the experience will be as physically and mentally tolerable as possible. And as we've talked about at this, earlier today about colonoscopies and stuff, I think, most of us know that if you have a patient who gets a terrible colonoscopy and has a lot of pain, they're never coming back to you again, no matter what they say. We're changing that now with propofol and other things, but people remember, we all remember that when we go to the doctor. There's always something that we remember that wasn't a good thing. And so why do we really care about patient experience if we're GI people? There's a lot of data suggesting that it correlates with better safety and outcomes in medicine. Hospitals have 2% of their CMS Medicare reimbursement tied to it as part of value-based purchasing. And it constitutes about 25% of that value-based purchase. So when people look at their Vizient scores and when people look at their U.S. News and World Report, this is one of those things that you can actually change for these health systems. Starting January, if you're in a hospital, this CMS now is tying 2% of your reimbursement for outpatient surgical and endoscopy procedures reimbursement to patient experience. And I'll go over what that means. The year after that, it's going to be for all of your ambulatory surgery centers, all your private ones. So it's here to stay, and I think we want to go over that with you. Again, reputation for if you work in a big system, you kind of live and die by U.S. News and World Report and Vizient. And at the, at Eric's level, what you do is like each month you get to see what UCSF's doing and everybody else. You're always comparing yourselves to everybody else. Like, got to be better than UCSF. And then it's important for marketing and web searching, and it's the right thing to do. So the triple aim, Berwick had sort of put this out. It's been now 2008. To improve healthcare in the United States, really there were three things. Patient experience, which really is quality and safety for patients from their perspective. You need to improve the health of the population. You have to do it and reduce costs. So this is triple aim. At the end, we'll talk about the quadruple aim. So how do we get this feedback from patients? Well, we've all over the years done homegrown surveys, and those are okay. There's federally mandated surveys that CMS requires. Those are CAPS. And just so if I say H CAPS, just remember H is hospital. And if I happen to say CG CAPS, the CG is the clinician group. But just remember H CAPS is what the hospitals use, and that's from CMS. There's national benchmarking surveys from companies, some of you in big systems, and nowadays 80% of physicians are part of big systems. So either you use Press Ganey, you use NRC, or you use a homegrown one. And I think Kaiser uses a homegrown one, of sorts, but you can, but they're big. You can look at, forget that, just look on Yelp and look on Google and just see what's going on when you look yourself up. And generally you'll see terrible things, because if people don't like you, they're going to send stuff. They don't send good stuff. They just complain on, about all the bad stuff. So that's why social media is not a good way, and actually hurts all of us. It hurts our reputations. And then there's also unsolicited complaints that go to hospitals, that go to health plans, that go to the state. So what do we do with this data when we get it? So I am the Chief Experience Officer for UC San Diego, and we get somewhere around 400,000 surveys a year. So this is just big data analysis on what do you do with this? Well, we use it to look how to improve. That's the main reason we're doing it. This is a gift from the patients. How do we get better? We use it to coach our members and nurses, physicians, whoever. We address quality and safety issues. Sometimes patients will say, there was no privacy in this area. And it was like, you're just HIPAA violating all over the place. Like, well, gosh, we didn't know this, let's thank you. And we kind of change it. There can be some safe, nobody washes their hands in a certain area. Okay, we're going to address that. There's a marketing, no question. I'll show you how we use it for marketing. And we also focus our organizational incentives. So if you want an organization to improve something, you put some money behind it. And so that's what we do. And so one of the things, has anyone heard of Net Promoter Score? A couple people have. Okay, Kevin has. So Net Promoter Score, this is the current currency of the realm for any kind of patient, any experience, be it Google, Amazon, your car, whatever it is. Whenever you get a survey you fill out, you're filling it out on a 1 to 10 scale. What they're looking at, it used to be, okay, how many times do we get top box? Top box is a 10. Well, now what it says is, no, let's look at this a little different. How often do you get the top box? We'll call it a 9 or a 10. But how many times, if people give you a 1, 2, 3, 4, 5, they're basically telling you that you're not so good. Actually, you're terrible. And so they're saying, who are your promoters versus who are your detractors? The people who give you the 1 through 5 are going to write to Yelp and all that other stuff. And then if you're a 7 or 8, who knows? So what we do is an NPS is you take your percentage of 9s or 10s, subtract from that the percentage of 0 through 6s, and you get a number. And so you can see in healthcare, go backwards. Can I go backwards somehow? Thanks. In healthcare, we're about 70 to 90. So keep that in mind. So and then you'll see for us, we want our folks to be 85, or 90 for an NPS. If you're Apple, your NPS is 47. If you're Amazon, your NPS is 25. So what does this say? It says that people like their doctors. They like their healthcare. They really do. In healthcare, we get rated better than if you're a computer company or selling things on the internet. But it's still a very competitive, and it's a very tight bell-shaped curve for this. So what does our organization do? We give $1,000 bonuses to 12,000 employees, not the doctors, but just everybody else. And so, but this is based on one measure, just one thing, these NPS scores. And what we've done now is we say, okay, we have 362 individual places, clinics, offices, radiology suites, offsite places, getting surveys, and we look to see what percent of them we want them either to have an NPS of 85 or we want them to improve by 0.5, 1, or 1.5. And then we use that to be able to give them their bonuses. And by doing this, we really push the entire organization because everyone knows that their area contributes to this and they want to get the money at the end of the year. And so it really keeps an organization focused on what the goal is for the CEO and everybody else. What we also do is, we do a little bit of competitiveness and a little shaming. And so this is where we have all the specialties. You guys probably can't see it, thank goodness. And so, but at the bottom is GI, that's us. So we're like way down here, unfortunately. Like that's GI, hepatology is much better. And then you get others up here. But what do? Is we show this and say, hey, we don't want to be lower than urology. We don't want to be lower than, neurosurgery. So we use this to kind of, help all of us get better. But you can see now that we're, most of us are above 85 on NPS. So it really does, by looking at the data, it's just like looking at your ADR. If you never look at your ADR, you're never going to get better. If you never look at your Net Promoter Score, you're never going to get better. Once you do, you say, oh, I don't want to be that person. So you moves it up. And then, yes, you can't see this, but what it does is it goes into, we get a breakdown of all of the different, domains that you might be getting, with this. And so the one that what I do is I go through every department, every division. I meet with the urologist, the cardiologist, the neurologist, the CT surgeons. It's always the same thing. It's the same thing for everybody in this room, access. They're all going to say, we don't have enough access. Your access is the worst. And I haven't figured out who has good access, but we don't have good access in California. So maybe in Virginia, there's good access, but not for us. So it's always access, but there's other things that you look at, and that's where the teams can go over to see how to improve. What we also do is we share with the physicians what their scores are, and we send out physician scorecards on the 15th of the month. They get this, and we even include our affiliated physicians. So my wife is, it's like really a bummer having a wife who's like also a doctor who gets these, and she's like the best on the planet. So she's like gets 100 score on everything. So have you gotten your scorecard yet? It's like, don't even talk to me. So, but there's, but you see that there's always, it's a bell, most of them are, can you go back again or forward? Sorry, forward. Go forward, one more, forward. Okay, there we go. And you can see that most of them are at the top and really good, but there's some bad ones in here too. I mean, there's like couple ones, and I always have to tell physicians, it's okay if you get, someone gives you a 1 and they protest it. We have a whole mechanism where you can protest it, but it's like, don't worry. The good thing about these surveys, you're getting hundreds of them. So at the end of the day, it goes out in the wash, as opposed to Yelp, where you get 4 surveys, and if 2 or 3 of them are bad, it makes you look like you're bad. No, those are the 3 out of 300. So they're actually really good. We also give, on the right-hand side, we give the comments that the patients actually gave. This is actually a physician wellness technique that we do, because most of the time we don't give you feedback that your patients love you, and sometimes they give you a gift or they tell you that. But here you're getting like ream after ream of patients sending stuff to you saying, we love you. Our response rate for the surveys are 30 to 40%. It's insanely high because we use a telephone way of getting them, and people just leave comments. So it really is a good way. We give this as positive feedback to the docs. We also publish this, like in, the CEOs and the CMOs will put this everywhere. And we give star ratings to this. They're 5.0, 4.9, 4.8. So, my wife's a 5.0, and I'll never be a 5.0, but that's okay. So and then here, like Dave Kunkel is on this, and several of the GI people who are on this. So it really is kind of a positive thing, and just reinforces, hey, you're all doing a great job. And a lot of people are on this. And then we use it for a search rank. So if you, it's interesting. I tried to search some of the UCLA people and some of the other people. I'm not sure you guys are doing this. All the most Stanford and UCSF and all the other places are doing it. So you do a search rank, like for me on Google, and you're getting it used to be that Yelp or Health Grades would be the first thing that comes up. Not anymore. Google does their searches by star ratings. And if you have a star rating, you go to the top of a Google search, the bigger your N size. So suddenly UCSD is like right at the top above any other social media. And then what we do is we have it, you see your stars, and then if you click on it, you see all the comments, and then people can read it. And it turns out that again, we talked about earlier today with colon cancer screening, for the generation 50 and below, they go online and they check to see where they're going to go to choose their health care. It's not just word of mouth anymore. So people are looking online for where they're getting their care, and they use it to help choose. So this becomes a big part of marketing for us. Now, switching over to ASCs, there's several, I don't know how many of you actually do patient surveys, and it may be just homegrown ones. ASG has an old patient survey that they've had out in the past. It really was never validated, I don't think, and didn't have a benchmark. In Britain, they have a nice one through the NHS called the Global Rating Scale, and they keep on, updating that one. There's the GSQ, which I'm pretty sure is out of Canada. You can get from NRC or Press-Ganey, the vendors, sell surveys, but the coin of the realm is OAS caps. So that's just remember OAS caps. That's outpatient ambulatory surgery caps. And remember, caps is basically it's going through CMS. And so we look at this, and we look at our outpatient ambulatory, and again, it's like kind of a little bit of a shame and a little bit of a celebrate kind of thing. So GI is, we're kind of, as long as we're not at the bottom, we're pretty happy, but we have room to improve. And these are all the different OR places and things of that sort. So we look at this, get people's attention, and then you, again, just like we did for the clinic, you dive into what's going on, what are the different things that are in this, and you can get the sub groupings here. Here's the OAS CAPS announcement that came out last year, which talks about what's going on. And here's the important thing for you. Starting in calendar year 2024, which is 6 months from now, hospital outpatient centers are now required to do surveys. All you have to do is do the survey. If you do it and you have to send in I think it's 30 of them. You know, it's very funny how they do this, but it's a small number you have to send in to CMS. Then you can have the 2% that they were going to hold back from you. If you don't do the survey at all, they're going to hold back 2% on your pay for the ambulatory surgery centers. A year later, the same thing's going to happen for outpatient endoscopy centers if you're owned by AmSurg or one of these other places, a private one, that this will affect you too. Almost certainly what will happen will be that they will then, at some point, it won't just be, did you do a survey, but did you score a certain number? Did you something else? And it's not, this is not a hard thing. It's actually a good thing. It's like measuring adenoma detection rates. You know, it does make everybody better. They just want you to start doing it. So this is coming up. And this is the kind of what the survey looks like. And they're actually not bad. They say before the procedure, did you get information about your bowel preps? Did you get anesthesia? Did you talk to, if so, do you talk to the anesthesiologist? Did, you know, after the procedure, did somebody explain to you what was going on? Did they maybe call you after the procedure to make sure that you were doing okay? Did you have any questions about it? A lot of it is stuff that you would ask anyways. It's good stuff. It's not bad stuff, but you know, you'll start seeing more and more of this. So again, just want to get this on your radars. So in the final, you know, few minutes here, just want to talk a little bit about, well, what can you do to sort of improve your, you know, these scores? And this is, I took what, you know, Dr. Boyce put in his 2001 paper and we've updated it. AIDED is bread and butter. If your staff, if your team members, they need to know AIDED. This is just like breathing air. And so this is what AIDED is. And if you work at UCLA, it's called C-Care, but it's Studer Group and they just changed the letters. That's all they did. And so it's acknowledge, you go in, you greet, you make a personal, you know, good impression right off the bat, you introduce yourself and you start setting expectations. You know, you say what you're going to do and you give the duration. This procedure is going to take 30 minutes, an hour. You're going to be able to leave this facility in 90 minutes. Explain kind of what's going on. And just it could be in the clinic, it could be in the procedure. And then just say, thank you for coming. Do you have any questions? Anything I should have asked you that I didn't ask you? These are very simple things. Your front desk people should be doing this. Your nurses should be doing this. This is, you know, bread and butter. If anything, just introduce yourself is probably the most important thing. Because if you're sitting there in a room and all these different people are coming in, they don't know if you're who you are, but usually their biggest fear is that you're the medical student. And the last thing they want is like the medical students doing something to them. So you just have to do that. You also want to listen to your patients. This Amanda, she's actually one of my patients. She had a postpartum cardiomyopathy needed, got flown out from Arizona, had to have a heart transplant. And so she did well after heart transplant, but she talked to us and she had, you know, you guys don't realize when you're in the hospital and you're a patient, you hear everything going on you know, what's going on. You hear who's dating who and who's going to what concert and who's like mad at what doctor. And, you know, it's like, we don't want this. So just remember, you know, that, you know, people are hearing you, keep the chit chat down, especially, you know, in endoscopy rooms and where we just have little curtains, people are hearing everything. So you have to be careful. And this leads to on stage and off stage. It's really good that we're here at, you know, Ritz-Carlton. This is kind of, you know, people pay money to go learn from Ritz-Carltons or from Disney. And so this is how you learn you're on stage. So just for the record, I'm on stage, you're kind of off stage. We're all off stage from everybody outside at the hotel right now. But we're at work, if we're in the endo unit, we're walking down the corridors, we're walking in the building, we're wearing our UCLA scrubs out at the supermarket. You're on stage and people are watching you and like they're just processing it. In contrast, you know, you never see the, you know, the Disney workers smoking or, you know, drinking a beer or anything like that. You know, maybe they're doing it, but it's off stage. You would never see that. The same thing at the Ritz-Carlton. You know, nobody's doing anything bad here. And so again, remember when you're on stage, remember when you're off stage, you are being, as physicians or healthcare workers, being watched all the time. Access, you know, so anyways, you know, that's hard. We're all challenged right now with the post-COVID surge and the increase, you know, in demand for services with dropping to 45 for screening, but we're trying. Answer the phone. This is just for the residents, you know, but again, one of the problems is that we're all always frustrated when nobody picks up the phone when we call the endo unit or we call a nursing station or call radiology. Just pick up the phone and just, you know, and you'll be able to help out someone else, and hopefully in the future someone else will pick up that phone. Richard Branson really said it for, you know, for his industry. It's like the key is to set realistic customer expectations, and then not just to meet them, but then to exceed them in unexpected and helpful ways. So much of what we do in terms of healthcare is setting those expectations. It's okay if you're late, but if you've already set the expectation you're going to be late, then that's what you need to do. Anticipate what the problems are going to be, set those expectations ahead of time. This is probably the most important thing. When I go around and I tell, it doesn't matter if I'm telling CT surgeons or cardiologists, urologists, if you want to improve your scores, you just show up on time. That's all you have to do. If it's a 10 a.m. appointment, you go in that door no later than 10:03. If it's a video visit, you get on that at 10:02. If you do that, it does it. Just think if you go to the dentist, if the dentist showed up half hour late, you would A, be ticked, and B, you'll never go to that dentist again. It's like your time, basically they're saying, I don't respect your time. So you have to respect them. And we look at our data, and actually the data now, this is old data, is much more impactful. If you're more than 10 minutes late in GI, you're going to be in the bottom 10th percentile on scores right out the gate. So again, this is the easy thing to do to improve your scores from an office setting. The other thing in the endo unit is show up on time and be done, because your patients are mad if you're running late. Your colleagues are even madder if you're delaying them because they were supposed to be starting at 1 and they can't start. Be prepared. We especially get this, when we hear about the residents, the trainees, review the records ahead of time. Just don't go in there. And the worst thing you say is, so what are you doing here today? They're just, right there. They're just, you are not a good person. Those first impressions are key. Introduce people by their full name. And usually it's the formal name. Mrs. Smith, I'm Dr. Savides, this is, nurse, and give their full name. And Richard and I had to talk about this, how you introduce people. It's a big deal. And you don't want to just say, yeah, that patient, take that patient over. And then again, this is introduce. If you're in a room, introduce. And this is I'm Dr. Savides, this is the anesthesiologist, and give their name. This is the nurse, give their name and what their role is. It really makes a big difference. Something, again, for my students and my residents say, I only care about one thing, two things. Tell me, do they live with anyone? And what do they do for a living? That's all I care. If you give me those two bits of information, I'm going to be able to actually put together a pretty good picture of what's going on with this person, how to make them better. And then I also throw in the exercise part. But, but these are things that you can do that will give you a good idea of who you're dealing with. Manage up. This is just Harvard Business School 101. You're working with the best team today, the best referring doctor, the best this. It just, makes it good. Be mindful about dirtiness and cleanliness. Everybody's watching, especially during COVID. You have too many people walk around with their same blue gowns on and, maybe changing their gloves. Maybe they don't. People are watching that. Another tip is just when you talk to people, don't kind of hover over them. Sit down at eye level with them. It's infinitely better. If you've ever been a patient, it's not a good feeling having somebody kind of staring down at you. At Hopkins, they give you nice little personalized cards to say who they are and explain their role. And that's something I've liked. You can talk, give personalized tattoos if you want, but we won't go there. Keep your wounds clean. That's important. This looks like one of our, after one of these edge procedures or whatever, this is what it looks like. Just, you got to clean it. One of the reasons I like doing my cases in the ORs is that ORs are mandated. They have to have EVS clean it out every time. So I've got a clean room every time I start. If I go into an endo room, I don't know what I'm going to, it could never get cleaned. And then we'll just go quick. Warm blankets are key. No, if you're on a gurney and it's cold, just offer someone a warm blanket. It's the best thing you can do for them. And that will make them super happy. This is Brian Fennerty. He's drinking his Starbucks in the unit. Do not drink, your coffee in the unit. This is not allowed. Don't shine lights in people's faces. This was definitely one from that Worth said. There's a lot of people like music in their unit, but, I might not like Kanye, you might like Taylor, maybe we all want Miley, I don't know. But, either let the patient choose it or, do something else. So it's be careful. Another key thing for staff is never say oops or whoops or I've never done that before. That's like one of those, kiss of death. If my residents or fellows say that's like, you can't say that ever, don't say that. We have a problem with this with our physicians. They're texting during procedures. You can't do that. Like on iWatch, I can do it. No, that doesn't work that way. You focus on the patient, you don't do that. We've had problems with people with their cell phones in the ORs, and you don't take selfies with their patients when they're asleep. You just gotta focus. You also have to remember that patients may bring their cell phones in and may be recording you, so be careful of what you're saying during the procedure. We're going to skip that one, clean up, and then work well with your colleagues, memorable. Thank you notes are nice. We do that. An important one is just when you're calling patients back, the very first thing you should say is, this a good time to talk? Because, again, I deal a lot with cancer. I don't want to be, they're driving their kids to, somewhere. It's like, oh, you have cancer. Oh yeah, you're on speakerphone. So don't do that. And then the quadruple aim, getting back to Berwick, is, we're putting, patients in the middle, and, they're the center. So it's patient-centered care, and this, this high experience is all these things. But the other part is the provider experience. And so that's where we get into burnout, and that's part of the whole thing too. So that's a whole nother talk. But that's critically important for all of this. So if you want to read more about it, Luke John Day, who's currently one of the counselors on the ASG governing board, and I wrote this Patient Experience in the Endoscopy Unit. He's the CMO for San Francisco General, and it's got a lot of these tips and techniques in there. So again, it's all about teams. So thanks for your attention. Appreciate it. And I apologize, Eric, for going